Good morning and welcome to this channel again, YouTube channel Painfree Partha. And many of my slides are also seen in slide section of the website www.painfreepartha.com. So today's topic is about the renin angiotensin aldosterone system, and do we have anything in the anesthesia? So what are the three premium areas of work in which the RAS, renin angiotensin aldosterone system works? That one is about fluid volume, the second is about blood pressure, and the third is about the sodium balance. The sodium balance is intricately associated also with potassium balance. So fluid volume, blood pressure, sodium volume, and also some potassium balance. These are the three premium areas of RAS. The renin angiotensin is primarily associated with blood pressure regulation. How does it do? Again, go back again. It maintains blood volume. It increases sodium resorption, thereby water, thereby volume. It increases potassium secretion, water reabsorption, and it increases vascular tone, thereby the BP is increased. So this is the role of blood pressure regulation by the RAS. It is very difficult to understand before we go into the image. Now you see the blood pressure falls. The BP is false, whatever be the cause. For example, diarrhea, vomiting, whatever be the cause. Burns. The blood pressure falls will cause an increase in renin secretion, okay, from the kidneys. This renin, what does it do? It picks up the angiotensinogen which is secreted from the liver and changes into angiotensin 1 in the blood. Okay. Now this angiotensinogen 1 is from the liver. The renin is from the kidneys. This kidney renin secretion is increased by a BP fall. Now this angiotensin 1 gets converted into angiotensin 2 by the ACE, angiotensin converting enzyme. From where does it come? This comes from the lungs. This ACE converts angiotensin 1 to 2 and also some sort by the kinases. Now this is angiotensin 2. What does all it does? The primary action, it goes into the vascular system. It acts on the AT receptors, angiotensin receptors, causes vasoconstriction, increased blood pressure. This is the primary thing. Angiotensin 2 goes into angiotensin receptors. This is not angiotensin 1. This is receptors are classified. AT1 receptor, AT2 receptor. Don't think this is angiotensin 1. Angiotensin 2 sits on the AT1 receptors in the vessels to cause vasoconstriction, so to increase BP. This is one action. The other action, it causes into the brain. From there it secretes ADH. This causes antidiuresis, so this causes volume retention. So this is one. The other is it from the suprarenal. It increases the aldosterone secretion. This aldosterone from the kidneys causes sodium retention, water retention, and some sort of potassium excretion. So this is the basic mechanisms. So that is why this vessels increase BP rises, the sodium and water retention BP rises, this ADH BP rises. So BP falls, renin causes angiotensinogen to angiotensin 1. This angiotensin 1 is by the angiotensin 2 by the ACE, which is secreted by the lungs, and this causes 1, 2, 3 actions, and then sodium retention is also caused by this kidneys, and again the blood pressure rises. So this is how the BP is controlled by the RAS system. Now, what are the clinical pairs? What are the uses of this? Why do you want to use this drugs like angiotensin inhibitors, converting enzyme inhibitors? We want to block the system. RAS system want to be blocked. Why? This is hypertension, heart failure, acute myocardial infarction, diabetes mellitus, and albuminuria. So all these things are the clinical pearls in which we want blockage of the RAS system to have therapeutic benefits. What are these two drugs? These two drugs all prills and sartans. Enalapril, lisinopril, perindopril, all these things. These are all ACE inhibitors, angiotensin converting enzyme inhibition. What are sartans? Losartan, telmisartan, valmisartan, candesartan, irbesartan. All these things causes blockade of AT receptors. We know this is benzopril 40 milligrams, enalapril 2.5 milligrams, lisinopril comes as 5 milligrams, perindopril comes as 4 milligrams, ramipril comes as 2.5, trendalopril, quinapril, moxapril, fosinopril, and captopril. This was first launched. Captopril. These individual drugs, clozartan, candesartan, valsartan, olmesartan. All these so many sartans. So this is telmisartan and irbesartans. These are the drugs which act on the RAS. One is on ACE2 inhibition, ACE inhibition. Other is angiotensin receptor blockade. Now we know what are the effects. We have used in hypertension, we have used in heart failure, we have used in acute myocardial infarction to improve repair, and we have used in microalbuminuria. These are the 4 indications of these sartans or pills. Now, what are the side effects? Dry cough, hyperkalemia, fatigue, sometimes hypotension causing the dizziness, headaches, loss of state. Rarely, this AC inhibitors induced angioedemas. Creatinine. These 2 things we have to be very careful. When you start your enalapril, when you start your telmisartan, check BP again. First dose of the drug or second dose of the drug. Is it okay or not? Then 3 weeks later, you take one creatinine again. If it doubles, especially in chronic kidney disease, beware, stop. That is where we should stop in this AC inhibitors or saltons. Yes, we can give in chronic kidney disease, but we should check again creatinine. Whether the dose has hampered the kidney and creatinine has to be definitely concluded. Then only you continue your sartans and pills. Pregnancy is contraindicated because it causes renal problems in the fetus. Now we have the first picture. Now you see this is angiotensin converting enzyme. This causes blockade of this. So angiotensin 1 does not become angiotensin 2. So the BP falls. That is how the antihypertensive action is mainly. There are other actions also through aldosterone. This is about angiotensin 1 to 2. Now we have sartans. These act directly on the angiotensin 2 receptors in the vascular system. Thereby the angiotensin 2 cannot act, the BP falls, the vascular tone falls. This is about the sartans and pills. There are drugs called aliskiren which causes direct renin inhibition. This has gone slightly out because of problem in renal damages and all these things. This was available. The drug was around 36 rupees per tablet, aliskiren. I have used this direct renin inhibitors for hypertensives. Now we know this angiotensin and converting enzyme is not only doing this, it also does so many things here, so that if you block this, the leukotrienes increases, the bradykinins increases. Because your angiotensin converting enzyme, which blocks all these things, is blocked. So pills increases bradykinins and causes cough in the lungs. Okay, that is the pathophysiology of cough if you add enalapril or lisinopril. Now NSAIDs, your diclofenac, brufen, all these things decrease the effectiveness of AC inhibitors, ARBs. So often used by people with kidney disease to protect their kidney function. We have used sartans, lisinopril for BP and heart failure. Now, if you give NSAIDs, we should be having in the mind your enalapril may not act very well, because this is a very important perioperative implication. Whenever you use sartans and ARBs and start giving diclofenac BD, then you should be keeping in the mind that your sartans or pills may not act to the full of its efficiency. Now, there are a lot of things about this patient is on hypertensive patient. This patient is continually taking telmisartan or olmesartan. Can we continue this? This is the biggest headache among this anesthesia world. There are a lot of difference of opinions between consultants of the same institute. So there are a lot of articles. So consequence recommend discontinuing and they found in the literature. However, anesthetists should be cautious about the risk of intraoperative hypotension. Yes, the blood pressure falls because you continue this telmisartan, there is some sort of increased incidence of intraoperative hypotension, and this may need excessive vasopressors. This may be refractory to our routine vasopressor use. This is what is the problem if you use enalapril or ramipril and start giving, especially neuraxial blockade. Thus, withholding an AC inhibitors before surgery improve outcomes. Withhold enalapril 24 hours before has been associated with 30-day lower risk. See, 18% less death stroke. There are a lot of studies. Now, this study tells 24 hours prior, you stop this AC inhibitors for non-cardiac surgeries. Intraoperative hypotension is more frequent with patients with controlled hypertension AC test. Now, BP is controlled well with telmisartan. You are giving in the morning. You are giving a hypotension GA or regional, whatever it is. Your intraoperative hypotension is frequent than the patient having your calcium channel blockers. Withholding angiotensin AC inhibitors before major was associated with lower risk of death. See here, there's a big study. I think it's 14,000 patients or something. They have advised to withhold these two drugs before surgery because perioperative or postoperative vascular events are less if you discontinue the drug enalapril or telmisartan 1 day prior to the day of surgery. Patients on AC inhibitors about 50% risk of hypotension. Significant of these episodes are severe. Again, another article. There are a lot of articles. This is 2014, 21, 22 articles are also there. So significant proportion. One thing is the incidence of hypotension is more. The second thing is the severity of hypotension is more if we give your enalapril or telmisartan. Yes, there is another we should consider withholding is reasonable. They note that anesthesia related blunting of sympathetic vascular tone. Now, we have blunted the sympathetic vascular tone by way of some drugs. We have given vasodilators. We have given inhalation agents. So now your system is what? Renin angiotensin system is only to maintain the blood pressure. That is what is the problem here. Now we have blocked it also. We have blocked that also. That is why they say it is refractory. Angiotensin, there is another study, 2019 update, associated with intra of hypotension. It says further study more. This is only around, I think, 1,000 patients or something. For patients, yes, this is very clear cut Medscape, 2018. Stop all these drugs. Whenever it is there, discontinue 24 hours before. Now there is a problem with cardiac anesthesia. Now this patient is on an app. What they say is many states they have also stopped these drugs prior because if it is going to be a vasoplegic syndrome associated with this, then vasopressin may be only effective and it is refractory. Even in cardiac surgeries, your vasoplegia may be refractory to drugs and vasopressin only may act. All these things are there. That is why even in cardiac surgery, today 10 a.m. is the case. The day before 8 a.m. prior only they give. So 24 plus 3 for us is the gap which they give for telmisartan even in cardiac surgeries. But there are a lot of things it needs to be adjusted on case-to-case basis. Daycare surgery. There is one article which says it did not result in substantial pericardial hypertension. Yes. Discontinue does not result in increased hypertension. Okay, you have discontinued this. Lot of BP is 170-100. Nothing like that happened in daycare surgeries. Many patients are in a combination of telmisartan hydrochloride with hydrochlorothiazide, which is a diuretic. Now you have a telmisartan and you have a hydrochlorothiazide. You develop a chronic hypovolemia. So refractory hypotension is imminent. That is where we should be careful, because a lot of drugs, telmisartan, hydrochlorothiazide, telakh, and so many drugs are coming. So these drugs, if the patient is taking for 2 months or 1.5 months, they have good control of hypertension. But there may be an incidence of chronic hypovolemia where you will end up in a refractory hypotension after your anesthetic technique. Do we need to take potassium level? Yes, we know that the hyperkalemia is a side effect. We know side effect of hyperkalemia is a side effect. Hypotension is a side effect. Your renal damage is a side effect. Increased creatinine in 2 weeks is a side effect. Pregnancy is a contraindication. All these things we have already discussed. Now, cough is a side effect. Do we need to take potassium levels? No, because even in chronic renal deficiency, the potassium risk is there, but otherwise it is not needed to take sartans and potassium on the morning of surgeries. Vasopressin is the drug used commonly to counter. This is very important. When you get this thing, start vasopressin. When you think that this is enalapril induced refractory hypotension in a case of neuraxial blockade. Now we have given enalapril, you have given spinal anesthesia, you have got the BP fall, then you are giving ephedrine. Doesn't improve. Then you think of vasopressin and not noradrenaline. This is what I want to emphasize. Cardiac surgery, more complicated. It is so you have to take case by case basis, and many stop before the night. Vasoplegia is difficult to treat because if it goes into severe hypotension, is difficult. If there is some hypertension 150 100, it is easier to treat in these things, especially off pump CABG. Many people stop. There is a drug called ARNI. What is that? Angiotensin receptor and neprilysin inhibitor blockers. What is this neprilysin? Neprilysin, what does it do is, neprilysin increases bradykinins, increases ANP, increases brain natriuretic peptide. All these things are very good. We want ANP to increase, we want BNP to increase, all these things. So all these things are vasodilatation, decrease the sympathetic systems, and natriuresis, all these things are there. But if you add these things, all these things are happening. So you have neprilysin blockade, all these things are happening. But what also it does is angiotensin receptor also it blocks. So this is increased. If you block this neprilysin with your sacubitril, all these things are favorable. But this is not favorable. You have increased angiotensin. So that is why you add a sartan, valsartan, and sacubitril. So this is what is called ARNI. You have a neprilysin inhibitor, which is favorable for BNP, ANP, and all, but it is unfavorable for angiotensin 2. So that's why you add this sacubitril and valsartan. There are so many patients getting this, hundreds and hundreds of patients of cardiac problem with all your hypertension getting the sacubitril valsartan. There is no evidence is anesthesia whether to need to stop this drug or not. Yes, preferable to stop this drug before anesthesia. That is what is valsartan is talking about. Now we have already told NSAIDs does interfere. Yes, this is because the NSAIDs has problems. Afferent arteriole arrives at the glomerulus. They constrict the afferent arterioles, where AC inhibitors dilate this. So this will give, if blood is not coming, what is the use? So that is the problem. That is why your NSAIDs are antagonistic to efficiency of AC inhibitors. Yes, this is about anesthesia problems. Yes, we need to start immediately after the operation. Now there is a possibility that we may be called for an AC inhibitors related angioedema. Yes, that is possible, and people may be called for that. So beta blockers and AC inhibitors. Now, if you give anesthesia, there are two compensatory mechanisms. One is sympathetic stimulation, another is RAS. Now you have got a beta blockade or alpha plus beta blockade. Already your sympathetics are dulled. Your anesthesia is already going to dull your sympathetics. Again, if the patient has got captopril or enalapril, again, the RAS also is blocked. So that is why we say at least keep the RAS by stopping your enalapril. So that is, you get hypotension, which is correct. What usually I do is I stop 1.5 days prior. Telmisartan, Valmisartan, enalapril. Sometimes if the BP is very high, we can add some doses of amlodipine or something like that. Stop minimum. Yes, electrolytes are not necessary. There is one thing which I want to tell. Sometimes in FES nasal surgery, we may need hypotensive anesthesia. There we can think of continuing the drug because we want to suppress your RAS system slightly. Or in the morning of the drug, give the half the dose. This is my practice. So that your hypotensive anesthesia will be more efficient. You need not give so many drugs. Just you add your enalapril in the morning and then start giving with propofol agent and some sort of 15 to 30 mics of quinidine. 1.5 hours you will get good hypotensive anesthesia. But if you stop that enalapril, if you don't give beta blockers, then your response will be high after anesthesia. So the BP is difficult to get it come down. So that is one disadvantage, or you can take it as an advantage of adding or continuing Mesotons. My slides and channel.